One of the things that we often forget about antibiotics is that there are consequences, of course, side effects as well. And so we know that antibiotic administration, even in the short term, can affect normal gut flora. We can think of C. diff infections as a direct consequence of orally administered antibiotics. We can talk about the increase in the incidence of drug-resistant infections, and so this is usually complicated by the fact that patients require hospital visits and surgeries and come into contact with multiple drug-resistant bacteria that need obviously more stronger and more potent antibiotics. And of course, this is associated with an increased cost. We see antibiotics used inappropriately when there's viral infections, and the great example would be pediatric patients whose parents are concerned that their child is sick and are demanding some type of drug to fix the problem. And of course, wrong antibiotic selections that can affect future infections. And so an ear infection that's treated with something that's really more left for pneumonia or meningitis. We can also see antibiotic-resistant bacteria found in grocery store meat. And just imagine people who like not their steak well done, but their ground beef medium rare would be subjected to or eating potentially some type of bacteria, more often E. coli. The same could be said about parasites in sushi, or as well as undercooked turkey during the holidays. So we know that the normal gut flora contains good bacteria, and from a homeostatic standpoint, these bacteria aid in digestion. They regulate the GI environment. There's even some discussion that they can even biotransform or metabolize certain prodrugs, and we'll talk about that in a couple weeks. And so the concept here is that things like Greek yogurt and these probiotic yogurts that basically contain the proper types of bacteria would be something that you would take while being on an antibiotic. And of course, we know that antimicrobials can also kill normal gut flora. And so the main side effect that you typically encounter with any antibiotic is diarrhea. And that's the most common side effect with almost all these drugs. Constipation can occur too. But an outcome that's often unanticipated or even maybe not even acknowledged is the fact that when some of this normal flora dies, there is going to be a change in the way food and drugs are absorbed from their small intestine. And of course, you can allow bad bacteria to grow, producing a secondary infection, which would be something like C. diff. And that's kind of the implementation of the Darwinian natural selection, artificial selection that we had talked about earlier. When you look up the dosing guidelines for a given antibiotic in a specific disease, you can see ranges often given. And so I really like this chart because what we're seeing here is the patient response variance along a range of doses for levofloxacin. Okay, and so here you can see a single dose of 500 milligram tablet levofloxacin is treated in patients in a community type setting. Okay, and you can see there's a very large area under the curve reading for the various doses. And so some patients have very little levofloxacin in their system, and other patients have quite a bit. And then there's this nice bell-shaped curve right around 50 to 75 AUC units. And so if you don't understand what these AUC units are, don't worry, we'll talk about this later. But this is just basically distributing the point that it's really difficult to show a relationship between drug exposure and a patient response. And so this is kind of a subtle point. So if you think of something like a beta blocker, which would maybe control blood pressure or heart rate, you can see a 10 milligram or a 20 milligram dose of that drug producing a reduction in blood pressure by 5 or 15 or 20 millimeters of mercury. Unless you're actively measuring the amount of bacteria per volume in the patient's blood, we don't really know how good of a patient response we're getting with a fixed dose regimen. And so there is a lot of variability. And so other things that can contribute to variability, besides the innate components of these bacteria to be resistant to certain antibiotics, include the patient's age, weight, sex, glomerular filtration rate, so how often or how quickly the drug is excreted, as well as their hepatic status, depending on whether or not this drug is a prodrug and actually gets converted into something else. And so trying to standardize doses in patients for antibiotics is pretty difficult. And so you can see kind of dose ranges for a lot of diseases. And those dose ranges, the low end is more often bacteriostatic, and the higher end is more often bactericidal. And the other thing to think about too is that whether or not the antimicrobial will actually get into the site of infection. And so if it's a systemic infection in the blood, that's relatively easy. The patient can take a pill, it'll go through the digestive system, and eventually it will end up in the blood. Or you can just skip that process and give it IV. The drug will be inserted into the blood compartment directly, and the effect would be even more, the effect to treatment would be more quicker. When you think about body compartments, and so the lungs, the peritoneal cavity, the blood-brain barrier, the urinary bladder, trying to get a specific drug at a high enough concentration for a long period of time is somewhat problematic. And so the antibiotic of choice has to enter those compartments and reach that therapeutic goal of that MIC or that MBC to provide adequate therapy. And so how do you get the drug in there? So there's other options. We can inject it intraperitoneally, we can inject it IV, we can have the patient swallow it, and it would, from a chemistry perspective, it will only get activated in the urinary bladder. We'll describe how that works in a couple weeks, don't worry about that. But other things that we can do is we can play around with the loading dose. And so you've all taken a loading dose, you've all taken Z-Pak, I'm sure. That's the drug that has, it's I think 5 pills, 2 pills the first day and then 1 pill every day thereafter. We can kind of front load so we get a very high plasma concentration initially, and then what we do is we kind of maintain a dosing interval to meet that MIC or that MBC, whatever it may be. Sometimes we may or may not take antibiotics with food because that changes how quickly these drugs can or cannot get absorbed. The other thing that we have to do is we have to consider how much blood flow to a given organ exists. And so there are some organs that have a much richer supply of blood than the other, and so we have to kind of take that into consideration. We introduced pharmacokinetics. We'll spend a little bit more time talking about how we can actually calculate these variables. That's a whole lecture in and of itself. But of course, understand that if we are going to do kinetic type modeling, that's costly, it takes time, you need technicians and so forth. And so having standardized ways to give patients these medications does help. And so of course that's what a lot of this literature is on. And so you can look up many of these different approaches to specific diseases and anatomical sites, and it'll tell you, what's the appropriate way to get that drug to that site. There is a relationship between the MIC and therapeutic dosing and clinical practice. And so we can further subdivide antibiotics into 3 main groups that are basically based on their pharmacodynamic characteristics. And so there are some drugs that have a time-dependent bactericidal activity. And so what we can do is we can look at the minimal relationship to drug concentration and ensure that it's higher than the MIC. And so great examples of this would be the beta-lactams like penicillin, as well as vancomycin. There are some drugs that are concentration-dependent bactericidal, and so these drugs demonstrate activity with very prolonged post-antibiotic effects. So that means after the patient takes the drug, there's still concentration-dependent killing, most likely because these drugs stick around in the system for long periods of time. And so the pharmacokinetic parameters like Cmax and AUC are really more important than the frequency of the dosing, because these drugs do kind of persist for long periods of time. So great examples of those types of drugs would be aminoglycosides, fluoroquinolones, and antiparasitic agents like metronidazole. There are drugs that have bacteriostatic effects, and they can produce a moderate to prolonged post-antibiotic effect. And so great examples of those drugs would be macrolides and clindamycin, tetracycline, and so forth. Here, the efficacy is dependent upon the area under the curve, not necessarily a fixed concentration in time. Okay, so these are all different kind of variations in terms of antibiotic dosing regimens. And so I don't necessarily need you to understand this specifically, but you'll see this implemented in real time as we go through some of these cases. This is a great diagram, and basically the take-home message here is that once you increase the dose of a bacteriostatic agent, you can actually make it behave like a bactericidal agent. And so just to kind of synthesize this information, I don't need you to actually know the real numbers. When you're looking at these curves that look more like this, that are more basically level, you can basically surmise that these drugs are bacteriostatic. Okay, and if the curve falls like this, very steeply, these drugs are bactericidal. All right, and obviously the red line here is the control, so this is the uncontrolled cell growth. You can see the population of these bacteria without any antibiotic, and the antibiotics are listed up here. This is how exponentially they are growing. And so